Welcome to our final lecture for the semester. Unit 10, Module 8 is about loss, death, and palliative care. Here are the 8 sub-competencies for this module. Please take a moment to review them. Loss can come in a variety of forms. It can be the loss of an ability, a job, a relationship, or a person as a result of death. Despite the type of loss, grief is often triggered as a response. Grief is an individual's emotional response to a loss. People grieve what the loss represents in their life in a process of reconstructing meaning. The meaning of the loss and emotions surrounding the loss are constantly changing. Grieving validates the personal relationship with the deceased for the bereaved individual. A bereaved person is someone in the period of mourning and adjustment after a loss. Grief is essential for both mental and physical health as a person adapts after losing someone or something important. Many researchers have studied how people cope with loss. Elizabeth Kubler-Ross is well known for describing the stages of dying. Her work was based on the idea that if people understand what dying patients experience, they can provide more competent and compassionate care. Her stages of dying are also known as the stages of grief. These stages can apply to any kind of loss, not just death. The stages include denial, anger, bargaining, depression, and finally acceptance. In the healthcare setting, the patients and families may express anger at God or at providers for allowing an illness to occur. Nurses should accept and support the grieving person regardless of the stage they are in. We help them verbalize their feelings. We avoid trying to change their emotions or push them into a different stage of grief. These stages do not occur in a set order. A person may not experience every single stage. They can move back and forth between stages as they deal with various feelings. They may experience more than one stage at the same time, and there's no specific amount of time required for any one stage. There are several types of grief. First, let's discuss anticipatory grief, which happens when someone is preparing for an expected loss. Signs may include preoccupation with the loss, or unusually detailed planning, or a sudden change in attitude towards that thing or person that's expected to be lost. Then there's acute grief. This occurs in the months following a loss. So it's a state of crisis after the loss happens. So during this time, people may experience functional disruption, which is at its peak. They're also preoccupied with the loss. Depending on the situation, grief may be accompanied by relief, guilt, anger, and depression. And there's shadow grief, which refers to brief moments of sadness intermittently triggered by reminders such as an anniversary or the smell of a perfume, etc. This is considered normal and restorative. Then there's complicated grief. So this kind of grief does not lessen over time. It can continue for many years, and it's often associated with insomnia, irrational anger, or emotional outbursts. Professional intervention is often required. It's more common after loss from suicide or after surviving a traumatic event. Some people refer this as survivor's guilt. Another type of grief is known as disenfranchised grief. So this is grief that cannot be openly acknowledged or publicly mourned. So relationships that are not acknowledged, for example, or known by others, or estranged family members. So when grief is not acknowledged by others to the full extent, that is what is referred to as disenfranchised. So the person grieves in silence, which can be very painful. The greatest obstacle for a nurse caring for a dying patient is the nurse's own unresolved personal feelings about death. These feelings can interfere with providing calm, supportive, and therapeutic care at the end of life. So nurses need self-awareness and reflection to understand their emotional reactions so they can remain present and effective for both the patient and the family. Nurses caring for grieving individuals must also be flexible, practical, resourceful, and optimistic. Gerontological nurses work with grieving families often, and they must develop strong therapeutic communication skills. They're known as professional grievers. So, some interventions for the nurse to effectively care for those that are grieving include first, introducing yourself and the nature of your role. Then you want to establish a rapport with the patient and their family. Learning cultural, religious, and personal meanings of loss is very important. We must always use therapeutic communication. For example, support the patient or family member by remaining at the bedside and offering a quiet, reassuring presence. Observe verbal and nonverbal responses. Use gentle, open-ended questioning where appropriate. So overall, building that trusting nurse-patient relationship is important. The goal for palliative measures, or often referred to as palliative care, focuses on providing comfort, psychological and spiritual care rather than curing the illness. So the goal is to treat symptoms rather than the disease. The focus is on quality of life, which becomes more important than the quantity of life that remains. Palliative sedation may be used to lower the patient's level of consciousness in order to achieve comfort and relieve suffering. Hospice is similar to palliative care, but it does require a provider to certify that the patient is likely to die within 6 months. So hospice care focuses on holistic care of patients who are dying. This can be done in a home or an institutional setting. Pain control is a top priority for hospice care. When caring for a dying patient, nurses want to encourage independence as long as possible for the patient so that they will maintain a sense of control. Providing adequate and consistent pain control is very important. This must be done on a regular schedule rather than waiting for the patient to ask. Pain control can also include heat or cold therapy, massage, music, or relaxation. If the patient cannot verbalize pain, we can use the Flack scale and look for signs such as grimacing or tense muscles. It's important that pain control is effective in the stages of dying. Skin integrity should also be maintained by turning the patient unless this is contraindicated. Pads should be changed also to promote comfort. So we don't want to hydrate the patient intravenously in the active dying phase. So the body can no longer manage hydration properly at this point, and IV fluids may actually cause discomfort. So there comes a time when we no longer use IV hydration when the patient is actively dying. We do want to assess for urinary retention because a distended bladder can be very painful. Of course, we always check for incontinence too, and again, we change briefs or pads to promote comfort in dryness. So the patient may require catheterization if the bladder is distended or they're unable to void. We want to manage symptoms and provide comfort, or medications, for example, for excessive secretions. We can reposition the patient or use certain medications. So you don't need to know this now, but there is a scopolamine patch that is placed behind the ear to reduce secretions. If there is excessive secretions, we want to turn the patient to the side and raise the head of the bed if the secretions are increased. There's also other medications that can provide comfort, for example, for nausea, anxiety, or even agitation. When caring for families of a dying patient, remember that unresolved personal feelings about death can be an obstacle for the nurse. This also goes for caring for the actual patient who is dying. So again, unresolved personal feelings about death can be an obstacle for the nurse. So self-reflection and education are very important. When dealing with the family, we want to encourage their involvement, such as talking to the patient or having family members help care for the patient if they are able. We want to provide information and medical updates daily, and teach them also what to expect as death approaches. We want to be supportive and use active listening, even if all they can do is cry. So understanding their personal, cultural, and spiritual traditions regarding death is very important. This can vary widely. For example, in many Southeast Asian cultures such as Cambodia, Thailand, and Laos, reincarnation is a belief that may influence decisions such as organ donation. They may refuse to have the patient's organs donated after death. In the Haitian culture, they often avoid open discussions about death. Western European families may show very few outward emotions and may remain stoic during this time. Nurse should always ask about advance directives and ensure that the patient's wishes are documented and honored. So nurses serve as a resource person, ready to answer basic questions about end-of-life decision-making. Nurses should ask about the presence of an existing advance directive and ensure that their advance directive still reflects the person's wishes. Nurses advocate that the wishes are followed. A key part in advance directives is the healthcare proxy, which refers to the person designated to make medical decisions for the patient if the patient becomes unable to do so. The nurse also should ensure that they are available in the medical record, and the patient must have documented what treatment options they want at the end of life, if possible. Euthanasia refers to the deliberate ending of the life of someone suffering from a terminal or incurable illness. Passive euthanasia is a lack of action, such as withholding medication. Active euthanasia is a direct action that such as administering medication that directly causes death. This differs from assisted suicide. This involves giving the patient the means to end their own life. So the patient with terminal illness is given the means to end their life and instructions on the way to do this on their own when and if they choose. So these practices are not legal in many countries and most of the US, but nurses do need to understand the definitions. After death, post-mortem care begins. If the patient is on a cardiac monitor, the dysrhythmia that confirms the patient's death is called asystole. If no monitor is present, the provider must pronounce the death. The nurse immediately expresses sympathy to the family and allows private time. Families may participate in post-mortem care only if they choose. We do want to allow the family to be alone with the body without intrusion or interruption. The nurse should remove jewelry if the family requests it and document all belongings. Paperwork for organ donation or autopsy may be required. The death certificate must be signed by the person who pronounced the death, which is the provider. At the top, you'll see a normal heart rhythm with the PQRST waves. The bottom is known as asystole, and this is what in movies they call a flat line. Postmortem care is the nurse's responsibility, but know that the nurse never has to do this alone. So this includes washing the body, removing the catheters, dressing the body in a clean gown, and combing the hair. It's important to close the eyes and mouth before rigor mortis occurs. A rolled towel or soft gauze can be placed under the chin to support natural positioning. After the family is finished, the body is tagged and placed in a body bag for transfer to the morgue. Throughout all these steps, the body must be treated with dignity.